Okay, this week we're going to be doing chapter 4 in our book, and it's going to be all about antibiotics. Some of the topics we're going to do is fighting bacterial infections, major classes of antibiotic drugs, the storage of liquid antibiotics, ophthalmic antibiotics, and treating complications of infections. Our learning objectives are to identify the major types of antibiotics by drug class, to know which auxiliary labels to use when dispensing major types of antibiotics, define therapeutic effects, side effects, and administration routes of major antibiotics, and to use the antibiotic and general drug terminology correctly in written and oral communication. Okay, bacteria are single-celled organisms occurring in most environments. They cause a lot of different infections, and it wasn't until the 19th century, like we learned before in chapter 1, when Louis Pasteur found out that bacteria was actually causing different infections. So, bacteria has been around forever, the infections have been around forever, but it wasn't until the 19th century that it was actually discovered. Infections are a condition in which bacteria grow in body tissues and cause tissue damage by the presence or by the toxins they produce, and that usually cause inflammation and a fever. Like when you get strep and you have a sore throat, it's all from inflammation, and you have the fever. That's just your body fighting it off. There are two types of bacteria. If the bacteria needs oxygen to survive, then it's called aerobic. If it doesn't need oxygen to survive, it's an anaerobic bacteria. Both types are responsible for causing different kinds of infections. One type of infection you need to know is nosocomial infections, and that's when a patient gets the infection while they're in a hospital. This is just a little picture of different bacteria shapes. It's also on page 72 of your book. All different bacteria have different shapes. So when they usually swab, they can normally see under the microscope what shape it is, and then they'll do the gram stain and know if it's gram negative or gram positive, and it just tells them how they can treat the bacteria. This is just a picture of the gram stains. Gram positive bacteria turns purple when they stain it, and gram negative turns red. And bacteria are classified by 1, their shape, and 2, their gram stain. So when we move on here, this is like the gram stain results and their related diseases. So if they do a smear of bacteria and it's a rod shape, then it's a gram positive, or if it's a gram positive, then it is a specific bacteria and it's related to endocarditis. If it's a rod and gram negative, it's consistent with E. coli or UTI. If it's a cocci shape, just meaning that it's round and it's gram positive, it's like a staph bacteria. Toxic shock syndrome can be related to that. If it's gram negative, Neisseria, gonorrhea. Curved or spiral rods, gram negative, septicemia, and spirosphetes. A gram negative can be showing that it's related to syphilis. Antibiotics work in different ways, depending on what kind of antibiotic it is. Sulfa antibiotics, they prevent folic acid synthesis. And the folic acid synthesis is needed to help make the DNA. So if the bacteria can't reproduce its DNA, then it can't replicate. It can't survive in the body. Some sulfa antibiotics are nitrofurantoin, and you'll have like Septra, and things like that. Some antibiotics impair the cell wall formation, which is the penicillin and the cephalosporins. Some of them do a combination of things. They prevent folic acid synthesis, impair cell wall formation, and block protein formation. That would be your macrolides, your tetracyclines, and your aminoglycosides. Some interfere with DNA formation. It looks like this this PowerPoint is just kind of going over the same thing over and over. Quinolones interfere with DNA formation. Cyclic lipopeptides disrupt the cell membranes. Metronidazole disrupts the DNA structure. When you dispense antibiotics, there's a couple things. The main thing is to swab the counting tray between drugs because you really don't want to prevent cross-contamination. Patients really shouldn't receive any kind of antibiotic at all unless it's needed. So cross-contaminating them with another antibiotic can, one, cause problems there, and two, a lot of people are allergic to antibiotics, either sulfa or penicillin or sometimes both, or and they can be really bad reactions. So you don't want them to have powder, like if you're giving them a clindamycin, but you just counted a penicillin, and that patient getting the clindamycin is really allergic to penicillin, then you don't want that powder being on there. There's a lot of side effects to antibiotics. Most antibiotics are supposed to be taken on an empty stomach, and that's just so it absorbs faster. Nitrofurantoin and cefuroxime are the exceptions and should be taken with food. The slide's just talking about antimicrobial resistance, and it's developing largely because of the overuse and misuse of antibiotics. Patients are going into doctors' offices telling them, hey, give me a shot of penicillin. Hey, give me, just whatever. I need antibiotics. I don't feel good. And if it's viral, an antibiotic isn't going to help at all. So people are getting them when they don't need them. And doctors will sometimes just prescribe them to get them out of there. Super infections can occur because of the resistance. Your discussion's going to be on this, so I don't really want to go too far into it. I want you to research it and kind of look it up yourself. The pharmacy technician should always place a label on antibiotics advising the patient to take all of the medication. This is because the doctor prescribes the antibiotic for 10 days because it will take 10 days for it to get rid of that bacteria in your body. If you start feeling better after 4 days and you quit taking the antibiotic, then the bacteria come back. It develops resistance to the antibiotic, and then you end up having to get on something else. It's just a cycle, and that's another reason why we're becoming so resistant to the antibiotics, because people aren't taking them all. How might the widespread use of antibacterial soaps affect the population? There are a lot of people who can't use antibacterial soaps, and a lot of germs that are becoming resistant to those because of the antibacterial in the soap. This is just the major classes of antibiotics. You'll see these different kinds a lot. Some more so in retail, and some of the other ones more so in the hospital. Just depending on where you work, you'll see more of one or the other. Our first class we're going to go over are the sulfonamides. These are also known as the sulfa drugs. They're effective against a lot of different microorganisms. They block specific steps in the biosynthetic pathway for making folic acid, like I said, which prohibits it from making DNA. It interferes with the PABA and folic acid formation, thereby destroying the bacteria. Oh, let's go back there. One example of a drug is the nitrofurantoin, the macrobid. One warning for patients is that it can turn their urine brown, and it can cause false urine glucose testing. They should not drink alcohol. They should take it with a lot of fluids and take it with food. Okay, next is penicillins. They have a low toxicity. There have been derivatives created by manipulating basic molecular structure of the drug. This is penicillin G, penicillin V, sometimes you'll see as penicillin VK, ampicillin, amoxicillin. There's also been drugs created for bacteria specifically resistant to penicillin. One of those is unicin. Penicillins kill the bacteria by preventing them to form a rigid cell wall. This makes the cell weak. It won't hold in the contents and the cell burst. Because human cells do not have a rigid cell wall, they're not affected. So that was the great thing about penicillin, that it can kill the bacteria without harming the normal human cells. Cephalosporins have mechanisms of action similar to penicillins. Cephalosporins are broke down into generations. There's the first generations, which you have your cephazolin, cephalexin. Second generation that you will see a lot is the cefuroxime. The third generations that you'll see a lot is cefotaxime, ceftriaxone, we use that a lot. And then the fourth generation is the cefepime. The first generations are used for mild to moderate community-acquired infections. This means they acquired it outside of a hospital. Second generation cephalosporins are used for otitis media, just meaning an ear infection, a middle ear infection in children, and for respiratory and UTIs. The third generation cephalosporins are used in more severe infections. They have a really long half-life, so they're used in patients that are usually children that need to take doses like before and after school, so they don't, aren't having to take it during the day. Cefepime is a fourth generation. It has a broad spectrum coverage. They usually use it to treat pneumonia, UTIs, or sepsis. It has been found that people allergic to penicillin have about a 1% chance of also being allergic to cephalosporin. So anytime you have a patient allergic to penicillin, it most likely will flag in your system that there's also a chance to be allergic to any cephalosporin they might be on. Depending on the reaction to the penicillin, most pharmacists or doctors will say go ahead and try it, especially in the hospital setting. They'll, because there's stuff there to help them if something happens. In a retail pharmacy, I don't really know much about what they would do there. It probably just all depend on the doctor. There have been new drugs created that are related to the penicillins and the cephalosporins. They differ. New beta-lactam drugs differ slightly in structure. The three categories are the carbapenems, the carbocephams, and the monobactams. The carbapenems are like ertapenem in vans. It's dosed once daily, so that's a good thing. It's injectable or IV, and they use it for severe community-acquired infections. The Primaxin, they don't use that a lot anymore. Honestly, I haven't seen one of those in years. It, it has similar side effects to the other beta-lactams, except that the seizures occur more frequently, which is why they switched to the meropenem. The Merum is the brand name, because it has the same coverage, but it's less likely to cause seizures. So that's probably why it's been so many years since I've used Primaxin as an IV. Carbocephums, Doripenem. It inhibits the cell wall synthesis to kill the bacteria. It's indicated for UTIs. And you have to be watched for seizures with that too. Lorabid. I haven't seen much of that. It's mainly used in kids, and it should be taken on an empty stomach. The monobactam is the aztreonam. We do use that a lot in the hospital. They use it for UTIs with good success and low toxicity. It's used against aerobic gram-negative infections, and the main side effect is a rash with that. Tetracyclines are broad-spectrum bacteriostatic antibiotics. They inhibit the protein synthesis in bacteria by binding to their ribosomes. They suppress the infection, but require phagocytes to eradicate the bacteria completely. The primary side effects of these drugs are GI upset, nausea, and vomiting. That's the main side effect on any antibiotic, really. The one thing to remember about the tetracycline is that when it comes to expire, it becomes really toxic and can cause a fatal renal syndrome. It can cause your kidneys to fail. Most antibiotics just gradually lose their potency, but tetracyclines will become toxic. There should always be an expiration date on it. There should always be extra emphasis on taking the entire drug regimen and not to keep it in your cabinet and take years down the road, because it could definitely kill you. They should also avoid sun exposure. It makes your body sensitive to the light. It shouldn't be taken by pregnant women or kids under 9, because it can cause their teeth to turn brown. So tetracyclines are there's a lot of different adverse reactions with those, and I haven't really seen a lot of them, and maybe it is just because of all of the different risks, but just read more on that on page 82 and 83 of your book. Macrolides inhibit protein synthesis by combining with ribosomes. They're used primarily to treat pulmonary infections. The macrolides are your azithromycin, your Z-Pak, Zithromax, your clarithromycin, your erythromycin, all of those. They're really prescribed a lot. They should always be taken with food, because they can cause severe GI distress. And taking it with food can lessen that risk. Chitalides bind to ribosomal subunits and block the protein synthesis. They can inhibit newly forming ribosomes. Bacteria resistant to macrolides is also resistant to the chitalides. So the chitalides are mainly used to treat bacterial infections in the lungs and the sinuses. like mild to moderate pneumonia, acute bacterial sinusitis, and bronchitis. Quinolones have a strong rapid bactericidal action against most gram-negative bacteria and many gram-positive bacteria. Whenever we say bactericidal, that means that it actually kills the bacteria. It kills it by antagonizing the enzyme responsible for coiling and replicating the DNA. That creates DNA breakage and the cell dies. Quinolones are normally used for bone and joint infections, infectious diarrhea, UTIs, STDs, upper respiratory infections, and again, the main side effect is the GI upset. They shouldn't take it with antacids because it affects the absorption as well. Streptogrammins inhibit protein synthesis with the bacterial ribosomes. It's an alternative to vancomycin, and its side effects are similar to the quinolones: nausea, vomiting, joint swelling, dizziness. Before a streptogrammin is administered, the IV lines must be flushed with D5 to ensure that the drug does not come into contact with saline or any other medications. The Sinercid is a streptogrammin, and it inhibits the cytochrome P450, so there are potentially serious drug interactions with that. We talked about that P450 in earlier chapters. Aminoglycosides are used to treat serious infections. They inhibit bacterial protein synthesis by binding the ribosomal subunits. After the first dose, the dose is adjusted according to the plasma concentrations. The aminoglycosides are the most common drugs prescribed for sepsis. The only problem is that their major side effects are nephrotoxicity and ototoxicity, meaning that they're destructive to the kidneys and the organs of the hearing, which is why the plasma concentrations have to be kept up with. They can adjust the dose then. The table 413 is on page 87, and it has the most commonly used aminoglycosides. The one you'll use a lot is the gentamicin and the tobramycin. Sometimes you'll use the amikacin and the streptomycin. Cyclic lipopeptides bind bacterial membranes, causing the cell membrane to depolarize. When it does that, it leads to the inhibition of DNA and RNA synthesis and causes the bacteria to die. The big cyclic lipopeptide is daptomycin. It's cubicin. There is no generic right now, and it's stored in the refrigerator, and it's very, very, very expensive. It's used for complicated skin infections. And it's active in treating aerobic gram-positive bacteria. Its big side effect is hypotension, headache, insomnia, rash, constipation, nausea, diarrhea, and injection site reactions. The big thing about the cubicin is that when you go to mix it, it takes forever to dissolve. I'll give you a little hint when you go. I don't know if you'll remember this, but when you do a cubicin, if you kind of like hit it against the counter, it'll break up the big clump of powder into smaller pieces, so it does dissolve faster that way. But it's one of those that you can't shake or anything like that. If you do, it'll be all foam and it doesn't go away. So you have to just, when you squirt the diluent in there, you just have to do it really, really slow and let it sit for like 25-30 minutes untouched so that it doesn't foam up and you won't be able to use it that way. Other antibiotics, several important antibiotics are strictly distinct from those in the other classes or from each other. We'll go over a couple here. Vancomycin, clindamycin, Flagyl. Those are the big ones. Vancomycin, bacterial resistant increasing due to the overuse. You'll have, like vancomycin resistant bacteria that's causing MRSA in staph. VRE, those types of things. Strict CDC guidelines for handling and use of vancomycin. Vancomycin is also one of those where their vanc levels have to be checked all the time to change doses, because it can be nephrotoxic and ototoxic as well. One big thing about the vancomycin is that it can't be too concentrated whenever you're giving IV. Just because if it's infused too quickly, it can cause what they call red man syndrome. It's like a flushing, but they literally turn really red. Vancomycin can also be given orally for C. diff. And when it's given orally, you dilute the vial of the injection and just put it right into a bottle for them to drink. So you can only imagine how bad that tastes. Clindamycin has a broad spectrum antibiotic use. It can be used for acne. There's actually a cream, and it's a little jar, and it's all clindamycin, and it comes with a little bottle that you dump in, and it's the benzoyl peroxide that they use for topical on your face. And they also have, other creams and ointments as well. It's a penicillin alternative in dental prophylaxis, so sometimes you'll take one or two before you go to the dentist. It's successful against anaerobic pneumonia, bone and bowel infections, intra-abdominal and female genital infections. Its most serious side effect is bloody diarrhea, and if that happens, that the drug should be discontinued. This is just a warning that should go on the drug, that if a patient develops the diarrhea, the drug must be discontinued. Zyvox is another antibiotic used. It's can be given orally or it can be given IV. It is the first oxazolinidone approved by the FDA. It inhibits the bacterial protein synthesis, and it must be protected from light. Flagyl, it's an antibiotic. It should always have a sticker on it that says "Do not drink alcohol when taking this," because it causes severe vomiting. It's just really bad, and it can also cause like flushing and headaches and things like that. Metronidazole also comes in tablets and capsules as well. So pentamidine, they don't even know what its mechanism of action is. They should always be monitored when getting it, because the patient can develop sudden hypotension. The storage of liquid antibiotics, after the lyophilized powder, powdered antibiotics are mixed. A lot of them need refrigeration. Others can be stored at room temperature. A lot of times it's just a matter of taste. If they don't need to be refrigerated, they can still be refrigerated, because it does help the taste a little bit when it is cold. A pharmacy technician is allowed to tell them what the storage information is. Each bottle will have on the side how many days it's good for after it's mixed and how it needs to be stored. And it should also print off on your label as well. Table 416 kind of just has a chart of the different liquid antibiotics that you have to mix, if it's refrigerated or not, and its actual flavor. Ophthalmic antibiotics are just for the eye. Very few antibiotics have otic forms. They're very painful in the eye. Otic medications have different pH in the eye. Otic medication shouldn't even be put in the eye because they're not sterile. So eye drops can be put in the ear, but ear drops should not be put in the eye, because eye drops are made sterile. Ear drops aren't. Ophthalmic antibiotics are those that you get, like if you have pink eye, and they have the tobramycin, the moxifloxacin, erythromycin, ciprofloxacin, even azithromycin, just for various things. The big one is the pink eye. And these are just discussion questions and assignment page. Just make sure that you do your study notes this week and your initial discussion posting. And then next week you have your review, your workbook, and your midterm is due on that next Sunday on the 1st. So just make sure you take your time, get everything done. Use your time wisely so you have plenty of time to do your midterm. And I also posted your final project on Canvas. It's not due till the end of April, but this way you have plenty of time to do it. But I think you'll really enjoy it. I was trying to make it something that you guys might be interested in. I know it's just a paper, but you might, you can pick a topic that you're interested in, you want to learn more about, or something that you had trouble with that you might want to learn more about, because I really want you guys to feel comfortable with what you're doing after this class. So let me know if you have any questions, and I'll be around, and I'll see you guys later.